This lecture is a summary of the history and latest developments in the use of intraocular telescopes for macular degeneration. I am the special advisor to NICE, appointed by the Royal College of Ophthalmologists to advise NICE on the efficacy and cost effectiveness of these telescopes. I have no financial interest in any of the devices which are mentioned in the course of this lecture. Age-related macular degeneration is the commonest cause of blindness in the over 55-year-olds in Caucasian societies. Most people have heard of the so-called wet macular degeneration, and in this new blood vessels grow on the back of the eye and cause severe scarring and severe visual loss. Treatment for this usually entails the use of injections into the vitreous, and this can result in visual stabilization. However, 90% of macular degeneration is due to the dry type, which is a generalized wearing away of the photoreceptors at the posterior pole of the eye, and up till now there's been very little that can be done to overcome this. Patients with bilateral dry age-related macular degeneration are seen in a low vision clinic. They're given some visual aids which have a varying use, and then invariably are discharged from the eye clinics. The prospect now, however, is to be able to provide some visual restoration to these patients. What is the size of the problem of macular degeneration and the epidemiology? As I've mentioned, it is the leading cause of severe visual loss in the over 50-year-olds. People with severe bilateral macular degeneration have a quality of life similar to a patient with a stroke who is incontinent. And not only does this indicate the severity of macular degeneration, one must also note that this is likely to become more and more prevalent in our societies as the demographics change. It has been estimated, for instance, that there will be a 54% increase in patients over the age of 75 years, and this therefore entails that macular degeneration will be double the problem that it already is now by the year 2020. Allied to this, one must look at the quality of life in patients with macular degeneration. For instance, there is about a 5 times higher requirement for home care with these patients. There's twice the rate of falls with fractures, and all this focuses into the concept that the social care of a patient at 75 who can see and the patient who is blind from macular degeneration is multiplied by a factor of 10. This latter figure is particularly relevant in the United States, where Medicare programs have realized that it is justifiable and cost effective to try and rehabilitate patients with macular degeneration using intraocular telescopes. Telescopes are of 2 main types, but the one that is usually addressed is the Galilean telescopic system, and this is used in the IMT, the implantable miniature telescope, and the Italian, an early variant, the IOL VIP. In the IOL VIP, the first telescope that was used in this country, the telescope is used to magnify and also to divert the image away from an area of macula which is scarred onto an area which is not scarred. I first looked at this possibility in the health service over 10 years ago, and in fact in association with NICE have drawn up a protocol for the pre and post-operative assessment of patients with intraocular telescopes, all of which ended up with the NICE approving the use of intraocular telescopes in the so-called Interventional Procedures Guidance 272. This is available for perusal and study closely via NICE. My initial study with the IOL VIP patients, my group, the Milan group and the Valencia group, found roughly similar outcomes, namely that one could double the reading ability of patients with intraocular telescopes. However, the initial IOL VIP telescope was associated with some complications the main one being the rate of unpredictable postoperative hyperopia, particularly in patients who are emmetropic and hyperopic. In addition, the prismatic effect of the telescope system in the IOL VIP proved to be rather unpredictable. A second form of telescope that I've used is the implantable miniature telescope, which again is used in a Galilean telescopic system. This does not divert the image, it merely magnifies by a much higher degree, usually by about 2 to 3 times. The IMT improves central vision and consists of a quartz tube with 2 wide-angle micro lenses. This IMT was studied by the FDA in America over a prolonged period of time, and a 28-centre study enrolled 200 patients who were analysed at least 2 years. The study assessed the best corrected visual acuity and the endothelial cell density. And in this study of the IMT, it was shown that about 60 to 70% of patients were able to improve by at least 3 lines of reading acuity, namely to double their reading abilities. There had been some initial concerns with the use of the IMT insofar as damaging the endothelial cells, or the layer of cells at the posterior surface of the cornea. But in fact, this study showed that this was not a cumulative matter and would not give rise to long-term damage to the cornea. So in summary, the implantable miniature telescope gave a much higher rate of magnification. It had passed the most stringent form of ascertainment, namely the FDA in America, and this then resulted in this telescope being adopted in America by Medicare to help rehabilitate patients with bilateral age-related macular degeneration. Their conclusions showed that 60% of patients gained at least 3 lines, that is double their reading ability. However, it is noted that because of this high magnification, there is a restricted visual field, and therefore the telescope could only be placed in one eye, keeping one eye for a reading eye and the fellow eye as a navigational eye. This video demonstrates the first patient in whom I implanted the implantable miniature telescope. I've already removed the cataract from this patient, and I'm now just clearing up the soft lens matter. Through a large incision, the telescope, which is about the size of a pea, is implanted into the eye. The telescope is hydrated, the eye is opened, and I've now placed the lower loop of the telescope into the eye, and now will rotate the upper loop into position. The upper loop is now in place and the telescope is centered, and now all that remains now is for the eye to be sutured. This usually requires about 5 sutures, as this telescope is very large and requires about a 12 to 13 millimeter incision. The sutures are carefully laid out and tied at an equal level of tension to avoid inducing astigmatism or abnormal curvature of the front of the eye. prevent an acute pressure rise in the eye postoperatively, 2 small peripheral iridectomies, or small holes in the iris, are surgically performed at the end of the procedure. This operation takes about 30 to 40 minutes under local anaesthesia, and the patient goes home at the end of the procedure. The newest lens we are introducing is the SML, the Chariot's Macular Lens. This has many advantages. It consists of a central 10 diopter button, which gives again a 2 to 3 times magnification. The great benefit of this lens is that it can be implanted into the eye of a patient who has already had cataract surgery, and this is in fact what we find with patients. The majority of patients with macular degeneration, in fact, have already had cataract surgery, and quite simply this Chariot's macular lens is implanted on top of the pseudophakic intraocular lens. When a patient wishes to view something for near, the iris constricts, and therefore activating the magnifying central button of the Chariot's macular lens. The other benefit of this particular lens is that it does not interfere with the peripheral vision. Here we show the lens being folded into position and injected into the eye through a tiny 3mm incision. The lens is then rotated to fit perfectly into position. In conclusion, these telescopes offer a great deal. We are now progressing from the IMT into the Chariot's macular lens, as I mentioned, for various reasons. 1, that this can be used bilaterally. 2, it does not impair the peripheral vision. And 3, it is reversible. It is important, however, to bear in mind certain aspects of management. First of all, patients should have a reasonable expectation. The patients should not reasonably expect to be able to drive, etc., but merely to be able to see faces clearly and to be able to read. The surgeon should have realistic expectations as to the outcome as well, and be careful not to overpromise. The ascertainment and follow-up of patients frequently involves cooperation with an optometric colleague, and all surgeons and patients should be aware of the possible complications of such surgery, and a comprehensive information pack will be made available to all patients should they be embarking on this form of therapy. Clearly, certain patients carry a much higher chance of significant visual rehabilitation, and in broad terms, the smaller the macular lesion, the more likely that the improvement is to take place. So for instance, patients who have macular holes or a less than 1 disc diameter of macular degeneration can be expected to have a very good outcome. However, patients with more than 2 to 3 disc diameters of macular degeneration are less likely to benefit. However, one is able to ascertain in the clinic which patients are likely to improve, and one is able to demonstrate to the patient and the family the improvement that is likely to be produced. Thank you for your attention, and we'll be very happy to see patients referred for this exciting and major development in rehabilitation of patients with macular degeneration.